Right.
Hi everyone. Today we are so happy to have Professor Debashish Chowdhury to our program here. I'm Dr. Nina Regens, and I'm one of social media editors of the journal Cephalalgia and Cephalalgia Reports. The article about episodic cluster treatment was published in the Journal of Cephalalgia and Editor's Choice. So we congratulate Professor, and we would like to start with asking, please tell us a little bit about yourself, your university, and your work. Thank you.
Right. So, hello, everybody. It's a great privilege for me to, appear in this video on the platform of International Headache Society, the social platform. And I thank Dr. Riggins and the editor, Dr. Sacco, for giving me this opportunity. Um, my name is Debashish Chowdhury. I am a director professor of a tertiary care institute situated in Delhi, in India. So we train the neurologist, and I am a headache specialist also. So I look at the headache clinic in our institute. And we have been doing a lot of research in headache, and we have a fellowship program in which every year two fellows, headache fellows, are accepted. And we actually impart a lot of training on headache medicine. I have a running headache clinic, and we have a database of about now 13,000 patients of headache that we have treated over last about 13 to 14 years. So that's a small bit from my side. And I will also like to point out at this time that last 6, 7 years, I've been focusing on greater occipital nerve blocks in the treatment of headache disorders, particularly migraine and cluster headache, because I find it to be cheap, easily accessible, and with a little bit of training and practice, anybody can provide this intervention to the headache patients. And we have shown through our studies that it really helps both in patients of chronic migraine as well as in episodic cluster headache.
Thank you so much. We do appreciate nerve blocks a lot in headache medicine, and to have more research in this direction is amazing. It's not easy for all of us to create such a well-designed study. Could you tell us a little bit about your excellent idea how to design the study for occipital nerve blocks? Because you did have a placebo arm in your research?
Yes. So to tell you the background, in cluster headache, the treatment part is divided into three arms. First is the acute treatment of attacks. As you know that the drug of choice is subcutaneous sumatriptan or 100% oxygen inhalation with a high flow rate of about 15 liters per minute. And then you put these patients on prophylaxis, on preventives, right? And you add the first line drug is verapamil. But you cannot just start verapamil on a very high dose from the beginning. You have to need to start slow and slowly move up to the dose. And it takes time. Now, till the time the verapamil dose, an adequate verapamil dose is achieved and the patient is started to respond, you need a kind of a bridge therapy. You need a transitional therapy. And for long, for cluster headache, two agents have been tried for this transitional treatment. One is steroids, oral steroids, and the second one is greater occipital nerve blocks with steroids with or without local anesthetic, right? Now, there is a German study by Obermann et al. That showed that oral prednisolone at a dose of about 100 milligram per day can be started as a transitional treatment. And if it's carried over for a period of about 17 days with a slow reduction in doses, generally the patients do very well. That is, that by 1 week time, a greater percentage of people compared to the placebo were actually having lesser number of attacks per week compared to the placebo. So, so there is a kind of an evidence, although it's one single study, but there has been a good study, a robust study, and that actually involved the guidelines that were set up by the International Headache Society for the preventive treatment of cluster headache. So it's a good study that showed that the oral prednisolone is good. But there are problems in that in the study, although there was not major, side effect or adverse effect profile different between the active group versus the placebo group, but the active group did have a significant increase in blood pressure, one. And I think that in many parts of the world, 100 milligram of steroids is probably would produce kind of a adverse effects in the form of facial swelling, in terms of the electrolyte imbalance, in terms of propensity to the bone metabolism abnormalities. As you know that in many parts of the world, the vitamin D deficiency is endemic, and they are prone to have fractures, and a long treatment of steroids, even if for the 17 days, might actually predispose to them to the bone metabolism abnormalities. And also, in some of the developing countries, infections are very common, and therefore a prolonged exposure to steroids may actually put them at risk of getting some new infections. Although in the German study, they did not find much of such side effects. But then the two studies came up on occipital or suboccipital nerve blocks, right? Greater occipital nerve blocks, or we call it sometimes the suboccipital nerve blocks, because the volume of injected is more than what is required for actually greater occipital nerve blocks. So there is one study by an Italian group and a Belgian group together by Ambrosini et al. And that was published in 2005. And that showed that, yes, a single injection of greater occipital nerve blocks at the end of 4 weeks would produce a remission in about 81% of the patients, 85% of the patients compared to the placebo. And also within the first week or so, within the first half of this study, they found that about 61% of the patients actually were headache-free. But the problem was that they were just calculating the proportions of patients. They were those who went into remission from day 3 onwards, from day 4 to the week 1, week 2, week 3, week 4, right? So they did not actually measure the weekly attack frequency, which is recommended by IHS for such studies. And secondly, in their placebo group, they found that there was a zero response. And this is slightly, unnerving, because as we all know, in headache medicine, placebo people, the people who are getting placebo, they also get some response, and that can be as high as 20 to 30%. So getting a zero response is slightly disquieting, and therefore, I think that study needs to be looked in from that perspective also. Now, the second study was done by the French group some years later, and they use another steroid agent called cotrimazole, and that is used in France. And they used a repetitive, gone blocks instead of a single shot gone block in patients with episode. And both Ambrosini and this French group study by Elisabeth Leroux included both the episodic headache patients, episodic cluster headache patients, as well as chronic cluster headache patients. So they were using the repetitive blocks of spread over about 9 to 12 days and then assessing the primary outcome. But the primary outcome was little different, because they were actually combining both the episodic and chronic cluster headaches. So they measured that how many patients, the percentage of patients actually achieved 2 or less than 2 cluster attacks at the end of about 9 to 12 days after 2 or 3 repetitive blocks. So they also found that at the end of about 4 weeks, there was a significant there was at least at the end of 2 weeks, there was significant difference. And at the 4 weeks, also these patients were faring better than those who were receiving placebo. Again, the problem here comes that one, that there was a repetitive box. Second, there was a combination of episodic and chronic cluster headache patients. So we cannot really generalize the results to either of these groups. And third thing is this, that the endpoint was not as per the IHS guideline. So what happened that I think in 2016 or 17, Professor Goldsmith's group published a review article and did a systematic meta-analysis of this, and they found that these are the lacunae that exist in the literature, and therefore a proper randomized controlled trial needs to be undertaken. So that was the genesis of starting this study and planning for this study that we wanted to have, and because we wanted a homogeneous population. So therefore, we selected only the cluster headache patient because that is the maximum number of patients fall into that group. 80% of the cluster headache patients are having episodic cluster headache. And that will not actually anyway have a kind of a distortion effect if you actually include the chronic cluster headache patients also in the study. So therefore, we actually included the episodic cluster headache patients. So this was the background of the genesis of the study.
That's excellent. And thank you so much. The amazing overview for all of us of literature and previous research. The cluster headache is not as prevalent in population as migraine. So your ability to see so many patients and have this wonderful group to have research on this population will help a lot of people. And how did you design the trial?
Right. So we went into the details of what are the recommendations of International Headache Society for conducting such a trial. And then we had this, clear-cut objective that when we are asking the question that does greater occipital nerve block help in these patients, help in what? Help as a transitional treatment. And therefore, we do not deprive the patients if they need the prophylactic, because that is the role of the transitional treatment, that it acts as a bridge. It is not to deprive the regular preventive treatment, but it is just to cut short the acute pain, the most intolerable pain during that period when the preventives take their effect. So that was number 1 point. Number 2 point was that we want to be very clear that you see that if you put a greater occipital nerve block by using a local anesthetic and steroid, and you compare with the placebo arm of a sham gone block with normal saline, people will understand because the local anesthetic is going to produce a numbness. So how will you mask that? So for that, we devised a method that before the injection of greater occipital nerve blocks, we actually applied a lidocaine jelly in both the groups so that the area becomes numb. And so after the injection, patient would not know that whether he has received the active drug or the placebo drug. So this was, again, a kind of a sort of innovation by us that we did to include in the study, right? And number 3 is this. Our main aim was to see that what are the effects in the acute phase, that is up to 2 weeks, right? Because by the 3rd week, anyway, if you are using verapamil is going to take an effect, right? Whether you give gone block or you don't give gone block. So you want to reduce the suffering of the first 2 weeks. So you would like to see how many patients are actually getting remission within this first 2 weeks, right? So we had this protocol in place in which we included the patients of episodic cluster headache patients who were having had a prior history of more than 1 cluster periods. And actually, our patients had about 5 to 6 cluster periods in the past. So they were all well recognized, well delineated cluster headache patients. So there's no doubt about that diagnosis. So we included that. And then we started, after randomization, the 2 groups received, 1 group received the greater occipital nerve block with steroids, methylprednisolone, 80 milligram, and 2 ml of lidocaine. And the other group received 4 ml of normal saline. And we did not start any preventive at that time, up to 2 weeks. And if the patients did not respond or they had recurrent headaches, then after 2 weeks, either the verapamil was started and then if required, the dose was escalated. So this is important from ethical point of view, because you are not depriving the patient of a treatment that is available and that is well known. And also you are able to more or less, kind of see the effect of your target drug, your test drug on the particular patient population and test your hypothesis. So this is number 2. Number 3. Number 4 point is this: we included the patients of cluster headache. You see, the cluster headache the cluster period has got a lot of variabilities. It can last for 2 weeks, it can last for 3 weeks, some people it may last for 6 weeks, right? So how do you know that if the results which you are getting is not because of a spontaneous remission? So for that, we created 2 caveats. One, in the inclusion, we had to take patients who are within 2 weeks of their onset of the cluster period. Beyond that, we did not take any patient, right? And in the exclusion, if their patients gave the history that consistently their previous cluster headaches lasted for less than 2 weeks, we excluded that patient. So therefore, in both ways, we could actually get the patient population where this hypothesis could be, tested, that the effect that you are seeing is because of the drug and not because of chance or because of the spontaneous remission. So that is how we devised the study. And then we also had an open label arm after 4 weeks, where if the patient continued to have the headaches, then they had an option of getting a second gated occipital nerve blocks or any other treatment that they desire, standard treatment that they desire. So we have not published that in this paper. The subsequent paper probably will come. And then we followed them up to 1 year, right? So this is also has a long-term follow-up of these patients. But specifically referring to this paper, we actually wanted to know that what is happening in the first 2 weeks, because we knew that by 3rd or 4th week, actually, both the groups will actually behave more or less similarly, because the verapamil is going to take its effect. So that is in summary of the, our methods.
That's great design. Were all patients on verapamil or only some patients on verapamil?
Yeah. So you see that there is another problem. Like, as you see in world over, many patients of episodic cluster headache who have had a bout and were prescribed verapamil, even if the physicians tell them to gradually withdraw after some time, they are not very willing because they fear the next attack so much. It is so excruciating. So, and it is everywhere, but in our country also, we had some patients where they would, on a very nominal dose of verapamil, they will continue. So we had 5 patients in each group who would on very low dose verapamil at the beginning, at the baseline. But then only about a certain number of patients required verapamil addition and or escalation in the active group versus placebo group. So I think I can give you a number for that. I think
yeah, that's perfectly fine. It's actually a little nice teaser for our audience to go and read the article. I
right.
just asked this question because I did see number 5 for both groups, and I
Right.
wanted to make sure that our audience understands that there were no immediate change at the time of occipital nerve block in other treatments. And it's excellent study because in real life, we also have people on doses of verapamil. In United States, we do have FDA-approved antibody which we can use during cluster, and we do have neuromodulation device
Right.
FDA cleared during cluster, and still we reaching out to occipital nerve block and discuss it with every patient because it's really one of the main things that can help patient right away. Sometimes effect can take like within 2 weeks probably, as shows on your wonderful graph in your article. So occipital nerve block very important. And from practical point of view, we always discuss with patient one side or both? Because pain and cluster headache can be on one side and mostly on one side.
Right.
What would you recommend?
So for cluster headache, we recommend the block at the ipsilateral side of the pain, the same side of the pain, we recommend that. But for chronic migraine, we recommend bilateral blocks. So I think that this has not been formally tested in a randomized trial, but generally it makes sense because about 90 to 95% patients of cluster headache would stay on the same side during their cluster bout. So therefore, it is important to modulate that side, the greater occipital nerve. And another thing I will tell you about the methodology, that we used a very robust, assessment protocol in which we did a mixed modeling, in which we categorized the random factors, which are the patients. We categorized the fixed factors, like the patient's sex, the patient's which treatment group the patient belonged. And we also had the covariates, like baseline, what was the baseline differences in various patients about the frequency. And with this random mixed model, random and fixed mixed model modeling, we got enough power to suggest that this effect which you're seeing in outcome is actually true and meaningful. So that is an important part of this study.
Yeah, and in the article, I looked at beautiful. You have graphical abstract there. You had beautiful graph. I think even showing from us clinician to the patient. Look, that's beautiful. You can see number of attacks going down for so many people. Would be really helpful for our
Yeah.
audience. What were the results?
So the primary outcome for us was that what was the weekly attack rate, attack frequency that has changed between the two groups over across 1 week, 2 weeks, 3 weeks, and 4 weeks. We took 4 weeks as a primary and the other weeks as a secondary outcome. And we found that throughout, after giving the active drug, you could see the downward trend. And at the end of 4 weeks, there was a difference of minus 3.4 attacks, which is highly significant because the baseline attack frequency was about 11 in the active group and about 10 in the placebo group. So therefore, I think the attack frequency definitely decreases. But more importantly, I would like to bring out the next graph, which suggests the complete remission, because that is what we want, what the patient wants. Patient do not want to have another attack, right? So with the drug, about half of the patients by the end of 1 week were having remission starting from day 3 onwards. And by second week, about two-thirds, about 73% were having attack-free compared to the placebo. So this effect suggests that this procedure, this treatment is very effective. And if you can achieve a 50% or 75%, remission rate by giving this drug, by giving this bridging therapy, then you are doing a great service to your patients. Patient would love it.
I totally agree. That's what we want. We want no pain, and cluster headache is one of those described as most excruciating pain person can have. So that will really help to us, our patients, and we again congratulate you on this amazing research and clinical work. And we really hope that we will see you again with more wonderful work at the Cephalalgia. And we appreciate this interview for Editor's Choice Cephalalgia. Wonderful article. Thank you so much.
Thank you. Thank you so much. Thank you.